Looking for a different approach in dry eye? Consider MIEBO, perfluoral hexaloctane ophthalmic solution for treating the signs and symptoms of dry eye disease. MIEBO, unlike other prescription drops, directly targets tear evaporation. Learn more at miebodifference.com. MIEBO should not be administered while wearing contact lenses. They should be removed before use and for at least 30 minutes after administration of MIEBO. In clinical trials, blurred vision and conjunctival redness were reported in 1 to 3% of individuals. For full prescribing information, visit the website.
You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, and welcome to CRST, the podcast. My name is Kendall Donaldson, and I was the guest editor for the August edition of CRST. And in that edition, we spent some time talking about adjustability and future IOL technology. So I'm very excited to be here today with two great friends and colleagues who have wonderful insights on this topic. I'd like to introduce my two guests today. The first is Dr. Marjan Farid. She's the vice chair of ophthalmic faculty. She's a professor of ophthalmology, does cornea, external disease, and refractive surgery at the University of California, Irvine campus. Thank you so much for being here, Marjan.
It's a pleasure. Thank you for inviting me, Kendall.
And then I also have George Waring, who's the founder and medical director of the Waring Vision Institute in Mount Pleasant, South Carolina. He does refractive cataract surgery at cornea and was previously at the Storm Eye Institute and was the medical director of the Vision Center there from 2012 to 2017. So I'm really excited to have you here with us too, George.
I'm so excited to be with you both, and I'm glad we get to do this together.
And I've learned so much from both of you through the years, and I really appreciate all your insights. I know I've called you both to get advice on premium lens technology and how to incorporate some of this into my practice. So thank you for all that through the years, but I thought we could maybe share our insights with others. And so I've been doing premium lens technology since I finished fellowship. Unfortunately, that was 20 years ago, and it's amazing how fast time flies by. But it's also amazing how premium lens technology has changed with cataract surgery, and now with refractive lens exchange becoming much more common. We're seeing younger patients. And so I'd like to touch on that trend too, because these younger patients can be really it can be really tough to meet their expectations. And I thought maybe we could discuss that a little bit, but I do find that I'm doing cataract surgery and lens-based procedures on many more patients, and they want that very crisp vision, plus they want the range of vision. Marjan, do you have any advice for me and for our colleagues that are listening today and meeting that challenge and meeting the expectations of these tough patients?
Yeah, absolutely. So I agree with you completely. I think even the age of cataract surgery for patients who have earlier cataracts, lens dysfunction, and I know George is an expert on describing, but that lens dysfunction that starts as early as our mid-40s, impacting quality of vision and driving patients in. A big part of the drive in for younger patients is also our technology is so good, and they hear about this through friends, neighbors. As the technology becomes better and better, the demand certainly become more intense. The demand for quality of vision and range of vision, both. And really, I think the onus on the ophthalmic community and surgeons is to be very familiar with different technologies that are now available to us, familiar with technologies that are around the corner and are becoming available as time goes on, and to be able to offer sort of a wide range of options for patients, because as we all know, no two patients are the same. Every brain is different. Every visual demand is different based on patients' lifestyle and occupations and so on. And so really it becomes harder to select the perfect lens for every patient, but it's exciting because we have so many options.
Yeah, I have so many patients that come in and they say, I want the best lens, and we have to get into this explanation of how there isn't one best lens. And, a lot of my patients have had prior refractive surgery, so prior LASIK, PRK, or RK, and these patients can be really tough to please. And again, as you mentioned, Marjan, they're coming in their 40s and 50s now. And I know, George, you've published multiple times on dysfunctional lens syndrome and given us some insights there. I mean, do you have any pearls in meeting expectations? Because again, we're struggling with the challenge of giving the patients the best crisp vision that they're expecting, like they had after their LASIK and PRK, but also helping them with range of vision. George, any insight that you can share would be helpful.
We have observed the same trends as the both of you, where this is the fastest growing segment of our practice, and it has been for a number of years. And that is the surgical correction of presbyopia, and that can be in the first stage of lens dysfunction, as as we with our colleagues defined it, the second stage, or the final stage at the time of cataract. And either way, we are faced with some choices, and that is making good decisions for the patients in a vision for a lifetime paradigm. So historically, people would come in asking for LASIK because that's what their friends had. Now patients are coming in asking for lens replacement because that's what their friends had, and it's really amazing because some people aren't candidates for lens replacement, or maybe they will be someday, but they're not yet because they're still too early on in the aging process. But then we have to stop and think, well, where does this go? And what are our other options? Well, historically, we've utilized a blended vision LASIK approach in these plano presbyopes, for example. But I think you would both agree that some of the most challenging patients are when they've aged through that, and now you're have to work around your hyperprolate cornea, where you may not be able to offer them the lens that they want. And some of the least happy patients you have are lens cataract intervention after a hyperprolate cornea. And so if they were going to get 5 or 6 years before they outgrew their blended vision LASIK, where they would have been better served with a primary lens replacement, was one procedure, better optics prevented the aging, then that all of a sudden becomes more intuitive. And so we've really adopted that concept in our practice and have moved more and more to primary lens replacement, where historically we've always taught for stage 2 lens dysfunction. We're really moving more and more towards it in stage 1 lens dysfunction. And that is for the reasons that I just described. Now, like I said, we still do blended vision LASIK in appropriate cases, just much less often. And we're much more readily will recommend to a patient to do nothing at this time because they're still reading too well. But all roads have led to an increased adoption of primary lens replacement earlier in life. And thankfully, we've got extraordinary technology. Although not the God-given lens, it really is the next best thing. And so it's a great time to do what we do.
George, I thank you for mentioning blended vision and monovision. Years ago, I just thought that meant, offsetting the non-dominant eye a little bit toward the myopic range. But now we have so many different forms of blended vision and monovision, whether it be with monofocal lenses, toric lenses, light adjustable lenses, and even sometimes mix and matching a monofocal and a multifocal. So blended vision and monovision has come to mean a variety of different things. And we're fortunate, as we mentioned, to be able to offer our patients all these different options. I wanted to take a moment and kind of focus on adjustability a bit more. So let's talk a bit about the light adjustable lens. I've been using the light adjustable lens in my practice for about a year and a half now. However, when I was kind of researching whether or not I wanted to incorporate adjustable technology into my practice for about a year prior to that, I was calling Marjan specifically and asking for advice because I knew she had practiced in a little kind of similar setting. And I really do appreciate all the insights that you shared with me, Marjan. But I was wondering if you could just touch on sort of your favorite patients and the best candidates for adjustable technology as you're finding to be the case in your practice.
Absolutely. No, light adjustable lens technology has been a game changer in our practice for sure. And we are at an academic institution as you are. And I think we may have been one of the first academic institutions to sort of incorporate this technology. And it certainly can be done in academic institutions as well as private practice. Certainly, there are many that have incorporated this technology very, very successfully. And I think the best patients, at least to start with, and sort of the lowest hanging fruit are the post refractive patients, patients who have had previous LASIK, PRK, in some cases RK. But these patients, we know their refractive predictability, despite our best efforts, despite even intraoperative aberrometry, we still don't always hit the target. And the nice thing is we have this adjustability at our fingertips, and we can give patients their final visual acuity can be, from a refractive standpoint, almost perfect, if you will, because you correct all of the refractive errors, those mild cylinders that sometimes go missed, even those all get tuned in with the adjustability. So these patients get really, really precise vision, which I love. And I love to be able to say, this is really the only lens where I can confidently say I can give you what we set as your goal. So those patients are very easy. I do want to say RK patients, I sort of put an asterisk there because RK patients, if they are regular, meaning that their topography is regular, their higher order aberrations are minimal, and they have previously refracted well, then they will do really well with light adjustable lens. If they have a lot of higher order aberrations, despite our best ability to refract lower order aberrations, we're not going to be able to correct those, and those will, limit their best vision. So I kind of don't go for patients who have very irregular corneas with light adjustable lens. The other patients that are great are patients who are just not sure. They're very picky, finicky patients do great with light adjustable lenses because, they're not sure exactly how much of a mini monovision or monovision they want. We know there's some depth of perception in both the original light adjustable lens as well as the LAL plus. And to be able to put the responsibility back into the patient's hands, that they have a role in their final outcome of their vision, is great for those patients who are really, really picky. And then, patients who want some range of vision and are averse to dysphotopsias, they also do very, very well with light adjustable lens. Again, the responsibility is back on them, and they're able to play a role in their final visual outcome. So it's been a game changer. And the more you use it, the more, our comfort with it expands, and the more we're able to offer it to, patients comfortably.
Yeah, those are really great points, Marjan. I also find that I like the light adjustable lens in post refractive patients. The point about RK patients is really key. I mean, you have to be able to refract these patients post operatively. So if the higher order aberrations are so high that we're not going to be able to get a reliable refraction on them post operatively, that could really lead to a disappointment in the patient, especially after they're paying so much extra money, because we do charge more for this type of technology than other options. And so patients' expectations are incredibly high. So I also find that I have a lot of very detail-oriented patients, engineers, physicians that are drawn to this technology. But we really have to do a good job setting expectations with them as well. And I do talk to them a little bit about blended vision and how that's a tool that we used, even though there is some extended depth of focus in these lenses, that we're going to be likely doing a bit of blended vision there too. And we've found in studies that about 85% of our patients are electing some degree of myopia in their non-dominant eye. So it does tend to be the trend. But when they feel that they have control over it, we can say, well, you may choose to have complete distance, but you may also choose, and it's in your own hands, that you might want a little undercorrection on a little residual myopia in your non-dominant eye. And the ability for them to be in the control of their own outcome is very appealing for a large number of those higher maintenance type A patients that you were alluding to. But I've had a couple RK patients where I thought, gosh, maybe I should have gone with one of the other great options that we have. And we're very fortunate to be able to have several different options as long as we set expectations properly for these aberrated corneas.
Absolutely. But also, being able to treat astigmatism down to the last quarter, I think is also one of the reasons that patients with LALs are just so happy. We can really tune out that last quarter, and no matter how well we do with our AKs and our toric lenses, a little bit of residual cylinder is not uncommon in our standard non-adjustable lenses, but the being able to completely treat astigmatism down to its last quarter diopter makes a big difference in the quality of vision as well for these patients.
Yeah, no, I agree. This has been a huge advance. One of the issues that I've found though is now that I have so many different options to offer patients, that it takes so much chair time to be able to explain this technology and all the other various technologies that we have available. And patients, we want them to be a partner in this process of deciding what we're going to do for them. George, I was wondering if you had any pearls in how you explain the various options to patients, any pearls to make this more efficient, because I think all of us could benefit. I know you run a pretty high powered refractive practice there. So any pearls you could share for efficiency and getting patients informed of their options and helping them along that process.
Our dialogue evolves continuously, and part of that is a response to ongoing technological advances, and this is just, it's such an extraordinary pace these days with the change in the regulatory agencies and um, innovation structures in general. So we're benefactors of that. Our clients are benefactors of that. A number of years ago, we, like many, sort of adopted a outcomes based discussion where instead of going through a menu of technologies and technological descriptors, we really just said, "Hey, what are your goals?" And let us sort of figure out how to best deliver it without getting into the technological discussion, and that served us well. And then over the last 4 or 5 years or so, we've sort of evolved, continued to evolve, and this is some of these early thoughts that I learned from Stephen Dell, was the concept of opting out instead of opting in, where I think traditionally we may talk about uh, refractive technologies, perhaps in a apologetic way because certain services may not be covered, and then overemphasize certain side effects and issues, and you're almost kind of trying to talk these patients out of advanced technology, and even just by calling it advanced technology, you're talking them out of it. Premium, you're talking them out of it. The concept was where we've moved to is, hey, here, let me tell you about how the eye works. You got to focus like a camera, the lens needs to be clear like a camera, and the film needs to work. We show them their focus problem, show them the camera's out of focus. When we show them their astigmatism, we don't really talk about the word astigmatism. We just show them they're out of focus. We show them the picture of their cloudy lens, and then we say that we have our recommendation is that to get you seeing the best we can, is that let's put the camera in focus. We'll put in a clear lens, and when we do that, typically we're going to want to fix another problem, which is your age-related loss of your reading vision, and restore that. Or in the case of the myope, preserve your reading vision because you wouldn't be happy giving it up. And so that's our recommendation. You've got these three problems, and while we're in there, let's fix whatever we can fix because you're living with it every waking second for the rest of your life. So with that said, we go on to reassure them that we can do as little or as much as they like. That some of these services can fall outside of insurance and Medicare coverage, and that's totally fine. We'll take great care of them depending on what their goals are. But if we skip some steps, that they may not get the outcome that they're looking for, their desired outcome. For example, in the case of the myope, who may want to retain their reading vision, typically they wouldn't be happy afterwards if they gave that up. So again, we educate them on what's covered, what's not covered, and ultimately leave it to them with the confidence that whatever they want, they're going to do great. But we also have described the opportunities that all are affecting their vision, and we in our practice really we sort of put equivalent weights on all aspects of their vision. So their distance focus is just as important in terms of how you see as their clarity with their lens, and their ability to read is just as important as their distance vision. So it's all important. Now, of course, there are different ways that you can achieve focus, and that whether it's spectacle correction afterwards or not. But the point is that here are the three problems in client-centric terms. Our recommendation would be to fix them, and you can always opt out of any of that if you like. But that's become the standard way, and we go on to say this is really the typical way or the standard way that we fix cataracts these days. And so it's not purveying that this is any anything excessive, extra luxury, so on and so forth. And it's true. This has become basically the standard way that we fix cataracts in or vision in our practice, whether it's at the time of presbyopia correction typically or cataract. But patients are also reassured that we can do as little or as much as they like. They're going to do just fine. So it really just sort of flips the script. And I personally feel we've done ourselves a great disservice over the years in the apologetic way that we approach this, where we emphasize all the potential issues and problems. Of course, we go on to describe that they're going to see their lens working. We want them to see this for a period of time. That's how we know it's doing its job. And as it may relate to diffractive implants, these lenses, reading lenses, what we call them, do not have a built-in flashlight or magnifier. So in certain conditions, they'll need good light or a very small, minimal pair of occasional use magnifiers. And that's just fine. So we're still covering all of the other parts of functional vision and limitations, but doing it really in a positive, enabling way, as opposed to a scary way that we're creating a barrier. We're trying to create a positive opportunity, and so that's really where we've evolved, and it really has been a changed. Our patients appreciate it, and it's really changed the awareness in our community about the opportunities for vision correction, which is really what we consider a cataract procedure in its purest form.
Great advice there. Yeah, I also use an outcome-based approach and try not to get into the details of this lens and that lens, and kind of talk more about, well, what are you trying to get out of surgery? And I try to kind of always focus our conversation on what outcome are we trying to achieve here, so that I can understand what they want. And I've heard Steve Dell, I'm glad you brought up his opting out type strategy that you mentioned there. I haven't quite been able to achieve that level like Steve has discussed. And so, I still kind of go from the bottom up instead of from the top down. But the outcomes discussion is really something that's easily relatable to patients, and make sure that we're on the same page. I tend to have that discussion myself with patients, but I also have two videos that I show to all my patients. One is a 7-minute video that goes over all of the different lens technologies in a very general way. And then I show them a 4-minute video just about adjustability of lens technology. And so they all see that. And then I come back and I talk to them again. I haven't really been able to delegate that to a staff member, but I delegate it to myself through video, and that saves me some time. Marshawn, I was curious if you had any pearls for efficiency. I really also don't like to talk about cost, and I try to save that for my staff to go into. But any pearls on what you're doing?
Yeah, absolutely. I think both of you made such great points. Some of that depends on your patient population as well. But certainly, I think you have to let patients know that these higher technologies are available. But in my mind, before the patient comes into the room or before I meet the patient, I've gone through their scans. So I know what is appropriate and what is not appropriate based on their ophthalmic history. And after, even just the first few minutes of talking to the patient, I have already in my mind narrowed it down to a couple of choices for patients. And so I like to not give patients a huge menu. I think it creates confusion and then they have no idea, and it creates more frustration, I think, on both sides. So I narrow it down to two choices, and I tell the patient, I say, I've looked at all of your test results. We've had a good discussion. I understand what your needs are. Based on this, these are the two choices. I said there are other technologies, there are other lenses, and I can go through those with you if you want, but really some of those I've ruled out based on several things regarding your personal history. And I really personalize this choice to your eyes. So I've narrowed it down to these choices, and they're usually outcomes based, as you mentioned. And that is a little bit easier for patients to get a handle on. And I give them two prices. Unfortunately, I have to give patients the prices myself. I haven't delegated that out yet, but I tell them this is, what is maybe standard of care. It may be all, astigmatism correction, in some cases, two or three choices, but really narrow it down and make it very, very clear for the patient. And that seems to create some efficiency. And most patients don't necessarily want me to delve deep into all IOL technologies available. And once you've built that trust, they trust you to make a good decision for them. So I go in strong with my two recommendations, and then they can choose.
You're right. They really can become overwhelmed. And I also try to, at the end of our discussion, I say, well, this is what I do recommend for you, just to kind of limit it to them. And I document that in a chart so then my staff can continue that same discussion and know exactly what I recommended. Also, about a month ago, I finally came up with the idea that I was just going to be able to put all the prices on one sheet and give it to them. And I just circle or highlight the one that I'm leaning toward for them. So then I don't have to go into it, but they have the whole price structure so they know. And there's no question about what I said to the patient or misquoted to the patient or anything like that. So, that kind of takes away the discussion from the money, and they still have that information to take home with them. So that was really helpful. So we only have a little bit more time, but I wanted to touch real quickly on sort of future types of lenses that are out there, future technology that we're excited about in the upcoming years. And I know, George, you've done quite a bit of research on this, so I thought maybe briefly you could give us a little insight into some of the upcoming technology, because I know you're super involved in that.
Oh, very happy to. The the landscape is rich. The innovation pipeline is hot, and there's so many neat things going on with adjustability. And I sort of think of this in two broad categories. There's modular IOLs, and then or indirectly perhaps adjustable and directly adjustable in a non-modular fashion, whether it's through light source or a laser, a different type of laser, such as a femtosecond laser. Some of the, I think, things I'm most excited about that we've been working on for a number of years, one from each category perhaps, would be refractive index shaping. The company is called Perfect Lens, and this essentially uses a femtosecond laser to create a three-dimensional optical structure within an IOL. And we now have first in human data that is very, very promising, where on the bench we can essentially modify any optical circumstance that we can conceive of in an IOL repeatedly, without the need for glasses afterwards, or lock-ins, or stability. And this is all done in the clinic on most IOLs. And so this is holds great promise. And I think the most exciting recent human trials were changing a monofocal IOLs to multifocal IOLs with existing monofocals, and it's working. And so this is really, really, really exciting stuff. And this gets disruptive really quick when we think about the possibility where this could disrupt manufacturing and consignments as we know it. This can be a manufacturing process. And take it a step further, we could be doing this in our own ASCs or our own office-based surgical facilities, where we have blanks, where we can create the lens based on a perhaps diagnostic with adaptive optics visual simulators, where you export the visual circumstance. And you all raised a great point about the patient being involved. The patient would make the choice. They would choose their outcome, export it. That gets treated and imprinted into the IOL. You go implant it, let effective lens position take place, which there is no other way to account for with existing technology for the most part. We are now seeing tolerance to refractive error. That's a big, big, big positive thing in our diffractive lenses and some of our other EDOFs. But this is, you can come back and then fine tune it with a femtosecond laser in the office, repeatedly. So that's really neat. On the modular category, there are a number of modular lenses and other accommodative lenses in the pipeline. But in terms of adjustability, I've worked closely with the OmniView IOL system, which is a modular system with a shape changing base that simulates accommodation, and then an exchangeable optic. But I think some of the lesser known potential benefits beyond the obvious exchangeability and adjustability are things like capsule filling. This is a much more physiologic space filling lens profile that can near eradicate PCO, which is the main culprit with effective lens position changes over time. So you really don't see PCO when you separate the anterior posterior capsule leaflets. Plus, there's other interesting things. This is real estate for sensors, transducers, drug delivery, virtual reality, like we're seeing with the recently designed Google lenses for glasses. And then who knows, maybe there's additional safety features and benefits with stabilizing the anterior and posterior vitreous as well, in the fact that this is capsule filling, reduction of capsule stria, and so forth. So it's a really exciting time. There's a lot of innovation in the area, and again, this is all very upstream, so we still have a lot to learn. But I do believe this will be a big part of all of our future.
Great. Thanks so much, George, for reviewing some of those upcoming technologies. And if our listeners want to learn more about those technologies, we did cover those in the August edition of CRST. So I encourage you to go back and look at some of those wonderful articles that we included in the August edition. Some of the other things include artificial intelligence and how that's going to help us choose just the right patient for just the right lens technology. But I think at the beginning of this podcast, it was mentioned that we are very lucky to have so many different wonderful options for our patients, and the adjustability, the increased range and ability to accommodate, as George had mentioned, in some of those new technologies. So it's a great time to be practicing ophthalmology and cataract surgery specifically, and refractive lens exchange. But it's also a great time for our patients to be having surgery. And I think we all benefit from this, and our industry partners have been instrumental in helping us achieve this. And I wanted to thank you both, Dr. Farid and Dr. Waring, for joining me today for this discussion. And again, I hope everyone will look back at the August edition and take a closer look. So thank you for joining us for the CRST podcast.
For more shows like the one you just listened to, check out the podcast channel on itube.net.